let's go ahead and get started. So, my name's Nick Rowan. Again, a much a briefer intro and one that makes a little more sense for the group that I'm addressing today. So, I'm an ear, nose, and throat surgeon. I am somebody who specializes in managing sinus disease, nasal conditions, and as it turns out, the nose is a novel corridor to get to your brain. And so, about 40% of my practice is spent making holes in people's noses to take out brain tumors. So I work very closely with neurosurgery. And at the intersection of what I do, which is very unique to what I do as a surgeon, is managing my surgical patients and putting people in the hospital and being involved in surgical decision making, making sure they're safe for surgery, making sure they're going to have a good outcome, but also managing the disease process of what the pathologies cause. So stuffy noses cause smell loss. And my surgeries uniquely cause smell loss as well. Some of the tumors that I take care of cause smell loss as well. And so it's been a long time that I've been kind of using my clinical expertise to lead my research efforts. With that said, let's get into the slides here. I have some smell related funding. I have some industry funding that is for chronic rhinosinusitis trials, and I've been supported to do a lot of this smell-based research, which you'll see here. The only kind of real relevant disclosure is that I'm certainly smell biased. I think it's the most important sense, and I will try to woo you over here in the next 45 minutes or so about why it's so daggone important. But I'm a rhinologist, and I spend every waking minute of the day, more or less, kind of caring for people with these types of diseases, and I spend a lot of time thinking about this. So I certainly present my own personal bias and how important I think it is. But hopefully I'll convince you of that today, or at least kind of open your mind a little bit to these novel relationships with the sense of smell. So the mechanisms of the talk today is threefold. First, the first charge of the talk was really to kind of review kind of what I do clinically and kind of put some context of what clinically happens with the sense of smell. Then I'd like to talk about some of the unique relationships of frailty and olfactory impairments and kind of how this relates to aging. And then finally give you, this talk, I'm not going to go into fixing function so much, but just give you some little tidbits, some food for thought to, again, keep in mind how important and why the sense of smell is, so unique in its ability to regenerate and potentially even mitigate some of the untoward effects of unhealthy aging and how it relates to the sense of smell. So here's the basics. The sense of smell, it is something that occurs via conduction of the first cranial nerve. So you have 12 cranial nerves that kind of pop out of your brain. 11 of them, they all go to a different relay center and work in a certain way. Cranial nerve number one, the olfactory nerve, is the most evolutionarily ancient sense. It's distinct in its anatomical location and the way that it works. And it's the only nerve that kind of just sits out of your body, kind of hangs out in your nose, at the top of your nose. It's highlighted here in yellow. It's kind of high and deep in the sinonasal cavity. And I just spent the last, 3 o'clock here, 3 o'clock by you guys, last 8.5 hours of my life staring up at the olfactory nerve in the office with an endoscope. So it's very accessible. It's the only cranial nerve that's directly exposed to the environment, and it has direct access to the central nervous system. So any other sensory function that you have goes to a relay center. You have to figure out what you're sensing. It's in the thalamus, and then it gets projected out to your brain. The olfactory nerve is very unique in that it directly synapses with different parts of the brain, like the hippocampus, the amygdala, the entorhinal cortex, the cerebellum. It's very unique in its neuroanatomical connections. It's also unique in that it is one of the only nerves in the entire body that has regenerative capacity and neuroplasticity, meaning that it has the ability to change and improve and regenerate over time. So something like COVID-19, which many of us have experienced, we temporarily lose our sense of smell. Your sense of smell can return. It can improve even if you have an objective or a documented smell loss. How to test it is really important in what I do. It's also important in Dr. Chen's and my research, actually testing it. So you can ask somebody how their sense of smell is, but self-report on a scale of, for instance, 0 to 10, it's wildly inaccurate. One of my favorite things of the studies that I do is see how high we rate our sense of smell and then doing the kind of gold standard tests next to it and how poorly we all do on our smell test. It's completely discordant. So self-report, it's pretty easy to tell when your sense of smell drops from normal to nothing, like if you had COVID-19. However, slow downward trends over time are really kind of more or less, I'd say, impossible to detect. Maybe you know that it's not quite right, but you can't really tell what it is. It's like me telling you my blood pressure. I'm giving a talk right now. Maybe it's a little bit elevated. My heart rate's a little bit elevated, but I have no idea what the actual number is. Psychophysical assessments, they're really kind of the gold standard for people who both manage and research olfactory loss. This is done in a variety of different ways, all of which involve presenting an odor to a patient and asking them to detect that odor. You can do it with a simple scratch and sniff book. You can do kind of the Cadillac of smell tests with felt tip pens, which benefit from olfactory subdomains, which I'll talk about here in a moment. Finally, you can do actually objective tests, things like electroolfactograms, EEGs, PET scans, fMRIs. These are really used for research purposes only. There's not a whole lot of kind of clinical, honestly, even a whole bunch of research relevance for the majority of what we do as olfactory researchers. So I mentioned olfactory subdomains. There's three different ways to really kind of assess the sense of smell. Using these different types of tests. The one that's the most common is identification. So that's simply putting an odor in front of somebody's nose, putting it at a high concentration, saying, "Hey, what is this?" And you say, "Okay, well, this is peppermint. This is whatever smell it is." There are different kind of areas of olfaction, however. And identification is the most complex. So number one, it requires that you're able to detect an odor. So threshold is the concentration at which an odor must be presented in order for you to determine that there's a stimulus in the room, in the area. Discrimination is the ability to distinguish one scent from the other. So if you have cinnamon versus cardamom, I don't know the difference between the two of them. I might be able to tell you that they are different, but I don't know the names of them. I can't identify them, but I would be able to discriminate between the two. And then the most rigorous and complex of them, again, is identification. Not only do I need to detect it, do I need to tell that it's different from another odor, but I need to be able to identify it and say, that's cardamom. And I have to use my olfactory memory to determine that identification and to identify that odor. So what's olfaction used for? Well, we've all seen this, the exciting thing for Hong Li and I is that, this is, everybody's aware of this since COVID-19 happened. The sense of smell has been kind of front and center. And it has always been for me as somebody who's a sinus and skull-based surgeon. But the sense of smell is vital to the perception of our daily life. We use it for things all the time, food, drink, smelling our loved ones, smelling our kids, pleasant scents. It's also used for bad scents. If your kid's got a dirty diaper, you have some body odor. God forbid you have spoiled food in your fridge or your house is on fire. You can detect smoke. It can allow you to detect warning signals. So we use it constantly. It's one of those things that's always working. It's like our ears. We're maybe not necessarily used to it, but we are using it all the time, kind of perceiving our environment. The implications of olfactory loss are profound. My research life before I started becoming an aging and frailty guy over the past, 5 to 7 years was really a quality of life and outcomes guy related to rhinology type outcomes. And we know, and there's great data, I won't get into all of it today, but there is great data that shows that if you lose your sense of smell, you can have impairments and all of these things I've listed here in yellow. All of these things that are, mundane to our human life. Things like eating and nutrition come up all the time. I see patients on a regular basis who tell me that they can't taste anything. Well, actually, it's not their taste that's a problem. It's their sense of smell. About 90% of what we perceive as flavor, the feeling of food in our mouths, is actually from our sense of smell via the retronasal pathway, which is through the back of our nose. We know that patients who lose their sense of smell have a tremendous amount of antecedent depression and anxiety, and that losing the sense of your smell is a good predictor of those untoward outcomes. Olfactory dysfunction is incredibly common. The numbers vary incredibly widely, from as low as 1.5 to 25% of the entire worldwide population. This is secondary to really heterogeneous methods in olfactory assessments that are done. Smell testing is not very common. But olfactory dysfunction invariably increases with age. Here's a copy of one of the charts of our um, older adults who are enrolled in a smell training trial. And as you can see here, the total smell score, TDI, threshold discrimination identification composite scores, decreases as you age, much like other sensory functions. Your ears go, your eyes go, your balance goes. Lots of sensory functions decrease over time. But what really turned me on to this was about 10, 15 years ago. Mostly who I cite for this is a guy named Jay Pinto, who's at the University of Chicago, who does some similar stuff to what I do. There were some really, dare I use the word sexy, studies done on olfaction and mortality. And these studies said that olfactory loss is an independent predictor of your mortality, which is independent of other comorbidities, like all the other things that we think is going to kill us. So neurological comorbidities, cognitive dysfunction, cardiovascular disease, whether you have diabetes, whether you have cancer. Olfaction is the single strongest predictor than any other chronic condition. You can correct it any which way you want to do. All the smart people who are on this call, who are better at biostats and epidemiology than I am, nobody's been able to crack the nut yet. Olfaction seems to be a unique predictor of your mortality. And so I started to ask the question, well, is olfaction an indicator of reduced resilience? So thinking about what I do, I'm a surgeon. I talk about frailty all the time. I use this in my decision-making process. Frailty, I think this slide is worth reading for context. Frailty, the way that I think about it, is the syndrome of decreased physiologic reserve, resistance to stressors. And it's really a clinically distinct entity that is not just a list of bad things that can happen to you, but it is a syndrome, which is a continuum that ultimately there's a point of no return that ends in your demise, that ends in mortality. There's a couple of different ways to measure frailty, which Professor Chen probably saw in Toulouse, debates about frailty indices versus frailty phenotype, which we won't get into today. But it's worth knowing that you can use a frailty index, which is a list of essentially risk factors for unhealthy aging, versus the frailty phenotype, which is a physical set of measurements that has been shown to be a really wonderful predictor of untoward aging-related outcomes and physiologic reserve. So we know that the population is getting older. People are having less kids. Older adults are living longer. There's an increase in prevalence of older adults. There's an increase in prevalence of frail individuals. And we know that there's an inevitable march of sensory decline with age. And so I started to say, okay, what's the crosstalk here? Is there any sort of association between all of this? And as it turns out, the eyes and the ears have been well studied, and for a long time, people in my specialty have recognized the importance of hearing and seeing. And I looked in the literature and said, okay, is there any sort of relationship with the sense of smell and frailty? There was a systematic review back I think it came out actually in 2019, made the journal in 2020, something like that. And I started to ask, what about the sense of smell? And their line was that smell and taste were both understudied and heterogeneous. They couldn't find any solid data. There was a few publications on whether the sense of smell was uniquely associated with frailty. And so this is my question: is the sense of smell perhaps a canary in the coal mine? Is an indicator of some things that are bad to come? The OAIC is the Older Americans Independence Center. It's one of the local institutes that I have some funding on, and it's helped me to kind of fund some of the pilot data. So the first way that I looked at this is the same way that, many of you have probably, or your students at one point have looked up really good cross-sectional data if you're trying to determine for some sort of relationship. I use the NHANES data set, which for those of you who do not know, it's a national representative population-based study in the US, done every couple of years. It rolls about 10,000 patients. It's got mortality data in it, linked mortality data, which is really nice. And from the years 2011 to 2014, they assess smell and taste function. In one year, they just asked self-report. In another year, they did some actual kind of brief testing using a pocket smell test, which is a few items. And they looked at taste function. They saw if people could detect bitter or salty, two different types of salty. Then Haynes database is lovely in that you can create a outstanding frailty index because it has every medical comorbidity you could possibly ask for. So you can figure out the risk factors for unhealthy aging that people have. And so what we did in this study, I'm not going to get into the methods of these types of studies here, just kind of go over what the general message here is. But what we found in this first preliminary study is that when you compare olfactory dysfunction and frailty, we saw that self-reported olfactory dysfunction. So if somebody told you their sense of smell was down, if there was a psychophysical loss of olfaction, which is a scratch and sniff test, or if people reported that there was a self-reported taste dysfunction, there was a direct association between those three. There was no association between psychophysical or measured taste dysfunction with flavor. So when you put something bitter on somebody's tongue or salty on their tongue, they're actually able to detect it. There was no sort of association there, but sure enough, olfaction seemed to have some sort of signal with increased olfactory dysfunction seemed to have a signal with increased levels of frailty. The taste dysfunction, I've already given away my answer to my hypothesis there. This is self-reported taste dysfunction. I suspect that people who report self-reported taste dysfunction actually have measured, have olfactory loss, and they're just experiencing flavor, not actually taste. A couple other studies that looked at this, one of which was our own, which is a follow-up study, kind of looking at all the things that live in my world, otolaryngic sensory loss. A nice study from 2017 looked at a population level association between an olfactory identification test and found that there was no relationship in our study. Again, showed that there was increased odds with self-reported olfactory dysfunction with pre-frailty, frailty in those who are most frail. So even if you could detect it, it was associated with increasing levels of frailty. So there's a signal. So, the theme of this, one of the themes of this talk is so what, is asking kind of the next question. So what? So it appears that there's impairments in olfaction, olfactory identification. They're associated with higher levels of frailty index. But this was done with super rudimentary smell tests. And it leaves a lot of questions. And the first question is, okay, what about this physical frailty phenotype? I'm here telling you that the frailty phenotype is very important. Or is this really just another kind of bad thing that could happen to you, like being overweight, like having sleep apnea, like having heart disease? That could be just some loose association with, the overall kind of aging process. Another question I had was, is identification, which is a central phenomenon, which tells you how well your brain is working, the only association, or is there something that's unique that's happening in the nose at the level of the neuroepithelium that is telling us what's happening as part of the aging process? So this Hongli, your comment was too funny. So I mean, I've done a couple of studies on NSHAP, and this is probably where this came from. And so NSHAP, for those of you who are not aware, it's another nationally representative population level based study, really nicely done. Jay Pinto, the guy I referred to before, is highly involved and it has helped get it off the ground. And the NSHAP study is longitudinal. It's really lovely in the fact that it has both the measures of a frailty phenotype. So it has things like energy levels, walking speed, grip strength, which are germane to the frailty phenotype. It also has self-reported olfaction. It has it has psychophysical olfaction using sniff and sticks of both identification and threshold levels. So the two kind of peripheral and central processes of olfactory function. Again, identification is central. It's reliant on how your brain works, how your memory works, whereas threshold is really just kind of what's happening in your nose. All my polyp patients, all my patients that I saw today with stuffy noses, their threshold scores are really low. For those of you who aren't picking up on the threshold identification differences yet, their threshold scores are really low. If you pinch your nose, your threshold is also decreased. Your identification might be totally fine. If the smell is really strong, you can still identify and tell what's going on there. But I wanted to kind of know what's happening. Is this relationship because of something that's happened in the nose, or is it just kind of representative of what's happening in your brain? Maybe your memory doesn't work. This study was also really nice in that it allowed us to study those individuals who are unaware of their smell dysfunction. So those who said that they had a normal sense of smell, it was good, but they tanked on their smell identification scores. What we found were really honestly pretty modest effect sizes, and this is by far not my sexiest publication, even though it did get some press when you dig into the numbers here. But we had the implications here were that there was an association between psychophysical olfactory dysfunction and frailty levels, and that the odds of frailty were increased in those who are unaware of their dysfunction. So perhaps individuals who don't know that they have smell loss were at heightened risk. Furthermore, in this study, we looked at the differences between the identification index, and we found that olfactory identification was associated with increased levels of frailty through both an index as well as the phenotype. However, the physical frailty phenotype, the one that relies on things again like walking speed, like strength, energy levels, and weight, was exclusively associated with what's happening in the nose. So perhaps the threshold scores, what's happening in the nose, is representative of what's happening physically in the body. So as your bicep weakens, your nose also weakens. And this goes back to some other really fun studies that I've had in the past, looking at the aging nose. We can actually see the nose kind of atrophying, just like muscle does over time as we get older and, sarcopenic. And, a frail person when you see one. Your nose actually does the same thing on the inside, which is a really fun kind of mental model anyways. It's not fun for anybody experiencing, but interesting to think about. So, what has this research led to? Well, I think it has helped to increase interest in looking at olfaction and frailty. There's a nice meta-analysis kind of combining some of the studies. I actually knocked on this publication a little bit because I don't think they included all of the appropriate publications, but a very nice study nonetheless put out in JAMA Otolaryngology Head and Neck Surgery this past fall. They looked at frailty and olfactory impairment, and they found the risk of frailty was 2.3-fold higher in greater in patients with olfactory dysfunction as compared to control. And they found that there was an increased frailty with increased levels of frailty. There was a greater risk of olfactory dysfunction, so much so that those who are categorized as the most frail had anywhere from a 2.7 to a near 8-fold increased confidence interval. And so, this publication really kind of helps cement a body of work that I've personally been trying to push out there and say, hey, this is an association, the sense of smell and frailty, this is real. But how does this really contribute to the literature, I think, is kind of the next kind of so what question. But we know already that sensory dysfunction is bad, right? We know that if you have hearing loss, if you don't protect your ears, there is a strong association between forthcoming dementia. If you can't see, you're at risk for falling down. You can get hurt. How does olfactory dysfunction compare to other senses? And so our group has looked at this as well, and we've put the sense of smell head to head with other sensory dysfunction. So on the left is a really fun study, one of my more fun studies that I've done, looking at the number of sensory impairments and telomere length. So telomeres, we don't need to get into telomeres, how important they are, or if they're important at all, but generally thought that as telomeres shorten in length, the shorter somebody's lifespan is going to be. It's a marker of overall senescence, and we demonstrated that as there's an increasing number of sensory impairments, your telomeres get shorter and shorter. Really fun kind of little factoid. We also have on the right here, and not a fun study, rather a study that I'm really proud of using the Health ABC data, showing these really nice survival curves of over time of multiple sensory impairments, that for each individual impairment you have, it ticks down your survival curve, so much so that it goes in order on this survival curve. If you can't see it on Zoom, that top line is no impairment. The second below is one impairment, two impairments, three impairments, four impairments. So for the increased number of sensory dysfunctions you have, your overall mortality increases. And so sensory dysfunction is bad, right? Well, if you dig into each of these studies and you start using the methodology that y'all are increasingly familiar with, and you start correcting for the remainder of the variables, like the remainder of the sensory dysfunction, the remainder of the risk factors. In each of these two studies, the sense of smell is a unique indicator of things like telomere shortening and overall mortality. So just like Jay Pinto's studies back from 15 years ago showing that olfaction was a unique predictor of mortality, even when you correct for things like frailty in these studies using physical function, the sense of smell is still a unique indicator of untoward outcomes like mortality. So what's the mechanism? Hongli, I think at one point you wrote me an email. You're like, what's the mechanism for this relationship? I said, dude, I don't know. I'm like, there's this, like, I could talk for hours and hours and we can spitball about this. I'm not really sure, But the first kind of obvious question is, are there any common pathways between aging, olfaction, and frailty? Well, we know that diet is something that I brought up already. Is there some sort of relationship between your nose and diet? And we know that older adults, they lose their sense of smell. I think that hopefully I've submitted that to you here. We know that olfactory dysfunction is associated with aging. Again, there's been a wealth of studies showing this. And we know that older individuals are more likely to be frail. Okay, so there's, these arrows are kind of representative of how these things work. But we also know that aging is associated with dietary changes. We know that olfactory dysfunction is associated with dietary changes, and those individuals who are frail also have dietary changes. So the big question is, where is the intersection here? I don't have time in this talk to get into all of these studies, and I really don't have that wealth of my own personal experience in this. But harkening back to the NHANES database, which is it's the National Health and Nutrition Examination. There's a lot of lovely nutritional data in this. So we went back to the NHANES database a couple of times and we looked at how olfactory dysfunction, the relationship between olfactory dysfunction and frailty is mediated by dietary function. And as it turns out, in our studies, dietary patterns that were high in protein and selenium and beta carotene were associated with lower levels of frailty. When we looked at the relationship between cognitive dysfunction, which we use, you can have a whole seminar on olfaction and cognitive dysfunction, as olfaction is a great oftentimes the first symptom of neurocognitive disease like dementia. When we looked at the relationship between olfactory dysfunction and cognitive decline, we found that, in fact, individuals that some of this relationship was mediated by your diet. So poor adherence to diets that are rich in poly and monounsaturated fats, independently associated with both cognitive and olfactory dysfunction. The opposite of which is suggesting that things like if you eat a diet that's rich in omega-3 fatty acids, for instance, perhaps your cognitive function is improved. There's some poor data in my world that says that taking omega-3 fatty acids may help improve olfactory dysfunction. I don't know that I necessarily believe it, but there is some data out there. So takeaways so far. Hopefully, I've suggested to you that olfaction is associated with increased levels of frailty. I've said it enough times. Maybe if I say it some more, you'll believe it. Psychophysical olfaction, it's really important. So actually doing smell testing rather than just asking individuals how their sense of smell works. And perhaps what happens at the level of your nose, olfactory threshold, is more closely related to what happens at your bicep or the syndrome of physical frailty. It's a unique symptom of unhealthy aging. I tried to give examples of how olfaction is related to your mortality and things like novel markers like telomere length. And again, maybe some dietary changes help to explain the relationship between olfactory dysfunction and why somebody with olfactory dysfunction would have unhealthy aging and onset of frailty. So as one of my mentors said to me, he said, "So what, Nick? Why do I care?" After I had put all this work into it. And I said, well, what if I can fix it? I'm a surgeon, I'm great after all, right? I spent all this time working on patients and I can cut things. Can we fix function? Well, first of all, I can't really fix it, but I'm going to try. And that's kind of one of my missions. First thing we can do is perhaps we can use olfaction as a screening measure. And then the real kind of holy grail of this is, can somebody improve olfaction? And if you improve olfaction, can you improve the experience of aging? Is there a way to improve that? So first of all, I think that olfaction can be used as a screening measure. It's easy to perform. It depends less on effort, having grip strength machines, having scales, having people run down a hallway. Space is very brief. It's easy to do. It's easy to do and identify individuals who are at future risk, especially if it's an early indicator. Our data, I showed those survival curves. I think that there's a wealth of literature out there that does show that smell loss is predictive. Indeed, we don't know if it's causative at all. We do know that it is, however, predictive. And so we went ahead and did this, and we looked at the predictive nature of olfactory dysfunction. And I work with a great Frailty group here who has a registry of older adults. And what we did were we had a case control study of 90 patients. It was over 100 patients, but after matching and really making sure that these individuals were well matched, we compared frail and non-frail older adults. And sure enough, as it turns out, across the board, across all subdomain scores, olfaction is an indicator of frailty. And I'd submit to you that it really offers an objective, comparable, something that we can all talk about and say and put a number on it, score, with less rigor than going to France and debating whether a frailty index or a physical frailty phenotype is more important. This is a number that you can just say, okay, olfactory score is such. A nice study by Jay Pinto late last year showed that people with anosmia, so complete loss of sense of smell, over a 5-year period had almost a 4-fold increase of onset of frailty. They did this even just using a brief 5-item test, which takes about 2 minutes to do. It didn't hold true for hyposmic patients, probably because their instrument was a little bit crummy. It wasn't super refined. It was only a 5-item test, but I think there's increasing data that using smell as a screening measure is really nice, and hopefully stay tuned, Hong Lee, for forthcoming publications from me showing that, comparing to things like cognitive dysfunction, the sense of smell, you can use it in real time, real patients, and compare it to things like MoCA and predict untoward outcomes like neurocognitive disease and dementia. Going outside of the neurocognitive domain, however, this is a picture of my wife on the right side of the screen. She's a head and neck surgeon. She's a lot cooler than I am, and she will take out your cancer, save your life, and reconstruct your face. And so I was talking to her and I said, what if we did some smell testing in your patients? And she has a litany of different degrees and set up a really lovely study looking at smell function as a way to predict outcomes in individuals with head and neck cancer, and see if there was a relationship between olfactory dysfunction or frailty in patients with head and neck disease. So patients who should presumably have pretty normal olfactory function at baseline or representative function at baseline. And so this study outcomes were actually on the line with most of the studies we published previously, in that individuals who had worse olfactory psychophysical scores also had increasing levels of frailty. In this study, this is kind of what I was describing before. Individuals who had olfactory dysfunction had a mean VAS score, a visual analog score. Out of a best of 10, they rated themselves a 9. So those with smell loss gave themselves a score of 9. So this says that you need to actually do the testing to kind of figure out where their sense of smell is. We found that those who had severe smell loss or anosmia had a 75% increased odds of frailty in this cohort of individuals with head and neck cancer that we were prospectively evaluating. We also found, and this is kind of fun, put your dollars where your mouth is kind of slide. We showed that individuals who underwent surgery who had olfactory dysfunction stayed in the hospital 3 days longer than those individuals with normosmia. And so if you think about hospital costs at a place like Johns Hopkins Hospital or University of Pennsylvania where we carry this out, this you can put a number on this, and that number is pretty big pretty quickly. Uh, and so I thought this was a really fun examination, looking at the sense of smell as a predictor of how individuals were going to do. Perhaps the most interesting point of this study, though, was that when we compared the gold standard frailty score of surgical patients to olfactory function, the frailty scores actually didn't pick up the changes in length of stay. However, the smell tested. So what we're using as our gold standard surgical predictor of postoperative outcomes was not able to detect a difference, but the sense of smell did. So perhaps the sense of smell is a better instrument than what we're using right now. This is a kind of pilot preliminary study. I'm not saying that it is, but it kind of gives a suggestion that perhaps it's something we should start using and start using quickly. So olfactory dysfunction is bad, and it's an indicator of bad things. What happens if we treat it and we improve olfaction? And this is a whole talk in its own, but this is hopefully kind of one of the next phases of my life. So last time I gave a talk on treatment olfactory dysfunction. I opened up the Wall Street Journal and I saw on the front page this is the lead article on the Wall Street Journal, and says Apple has a hot new product. It's a hearing aid. The world's most valuable company has just turned its top-selling headphones into low-cost hearing aids, and it's quietly a huge movement. And so the world is getting behind making sure that we can help people hear, because we know the strong association between hearing loss and incident dementia. Also, we know the critical importance of measuring vision over time to make sure that people aren't falling or having issues with their sight. There's immediate obvious complications of this. And I would submit to you that I think that olfaction is probably about 10 years behind, but has many of the kind of same potential interventions. And there's other great precedents and other types of sensory dysfunction, looking at the potential impact of improving the sense of smell and the implications on healthy aging. A couple of areas. I took out the slides right before I gave this talk, actually, about these next bullet points here that I've listed on this. But there are some geroprotective agents and strategies that Professor Chen just heard about when he was in Toulouse, probably, about mitigating aging. And I would submit to you that there is a growing body of evidence that anti-aging drugs may also be the same thing as anti-smell loss drugs. And so we're seeing this in the diabetes space, things like metformin. They're having, multi-million-dollar trials using metformin as an anti-aging strategy. Our group has showed in a couple of different ways that cross-sectionally and longitudinally that metformin can that's associated with improved olfactory scores and maintenance of your olfaction over time. But what I do a lot of when I see patients with smell loss right now is I counsel them on olfactory training. What olfactory training is, again, sorry, I took out the slides here. Olfactory training is very interesting in that, unlike these glasses that I'm wearing, I can't just take them off and squint my eyes and try to get stronger and stronger eyesight, or just listen to soft sounds and make my hearing better. The sense of smell, however, is actually the opposite of that. Like I talked in the first slide, I said that it has neuroplasticity, it's regenerative in nature. If you, for all intents and purposes, smell things over and over again, there is a strong body of literature that says that you can improve your sense of smell. This is akin to the way that you distinguish the difference between cardamom and cinnamon and whatever I said in the beginning of the talk. It's not a panacea. It doesn't improve your smell from nothing to being a Michelin-starred chef. However, we do know that the sense of smell is able to be trained, and that with repetitive exposures to different odors, your sense of smell can improve. It does not happen overnight. It does take time. It takes patient compliance. It is challenging. And so our group is working on some novel strategies to improve this. In the picture in the bottom left there, that's an olfactory training device. We have an associated app to help people go through their olfactory training strategies and be presented with odors over and over again. And the most fun thing about smell training is that not only is there a body of literature that suggests that we can improve the sense of smell, but also there's improvements in things like cognition as well as well-being. So even if you're normosmic, it shows that in older adults, things like memory, like visual memory, and other types of task-based memory are improved in individuals who practice smell training, which is a really fun and kind of exciting topic, and it kind of opens the door for a lot of different kind of therapeutic different interventions. But we're not quite there yet. We don't have a lot of great options for smell loss just yet. Again, we as a community are working on this, but it's something we're working hard on, and we're growing a ton of inertia on. So what can we do today? Well, I think the most important thing we can do today is we can, increase advocacy, increase awareness. We can utilize olfactory testing, and shoot, you can help a doctor get paid for it. We have no way to get reimbursement for olfactory testing right now. So to give you an idea, the upset costs my clinic that I'm sitting in here right now about $30 to buy one packet to do a single smell test. That adds up really quickly. The upset takes about 15 minutes to do. It ties up an exam room for 15 minutes. I'm out $30. I'm out 15 minutes of exam room time. It certainly is a disincentive for people to want to do it. People like me, people who are otolaryngologists. I think we also need to increase just awareness. I think the community needs to be aware that this is important. And, again, one of my personal goals is to think about making things like olfactory testing mainstream, something in the future that we can test in all older adults. So in addition to recognizing the importance of hearing loss, and in addition to looking at visual loss, perhaps we can examine the sense of smell, and we can look at that over time. And this is something that we can all use with increased frequency. So in summary, hopefully I've presented to you here today that olfactory dysfunction, it's pretty darn common. It has a pretty broad reach, ranging from things like quality of life and cognition to more dramatic and sinister things like frailty, mortality. It has a tremendous amount of association with other untoward aging associated outcomes that I didn't get into, but there's really much to learn. There are insights from olfactory subdomains. There's a lot to learn about the mechanisms. I'm fortunate to work in a place where we have a bunch of mouse models, but also great groups where we have prospective cohorts of older adults that we can enroll into these different trials. But I think it's going to take the world to start using olfactory assessments as a screening measure to really get the appropriate data and really know how to best use this novel sensory function. And so with that, none of this research would be possible without, all these pictures, all these people that I've shown here, as well as a bunch of others, many of who are students who have gone on to their residencies or started medical school. And the Frailty group here, who's been instrumental in me doing some of this work. So with that, I'd like to thank you, and hopefully what I said made sense. I delivered some sort of clear message, and I'll be happy to take any questions. Again, thanks for all joining virtually on your Thursday afternoon. Thanks so much.